Greetings to the readers of British Journal of Urology International. My name is Mufaddal Mamawala from Johns Hopkins Urology, and I'm going to provide a short video presentation on our recently submitted study, Risk Prediction Tool for Grade Reclassification in Favorable Risk Men on Active Surveillance. As we know, active surveillance has evolved to address the overtreatment from PSA-based screening. The goal of cancer screening is to detect cancer during asymptomatic stages without losing window of curability. Cancer screening, however, identifies some cancers that in the absence of screening would not have become symptomatic or caused harm, thereby leading to overdiagnosis. Treatment of overdiagnosed cancer can reduce quality of life without actually affecting the length of life. The current guidelines for recommending interval between prostate biopsies are as follows. The American Society of Clinical Oncology recommends doing a 12-core confirmatory trust-guided biopsy within 6 to 12 months of diagnosis, and thereafter doing serial biopsies every 2 to 5 years, whereas the National Comprehensive Cancer Network recommends doing a repeat prostate biopsy as often as annually. These guidelines, however, follow a more standard one-size-fits-all approach. And that leads to our rationale for developing risk prediction tools that can help inform decisions about the intensity of monitoring, that is, determining the frequencies of future biopsies based on one's assessed risk, and thereby helping us individualize management strategies for active surveillance patients. We developed our risk prediction tool using data from 1,374 men enrolled in the Johns Hopkins active surveillance study between 1995 and 2015. Our cohort had a median surveillance biopsies of 3. During the course of follow-up, 254 men underwent grade reclassification to Gleason score 3+4 and above, whereas 1,120 men still had Gleason 6 cancer as of their last biopsy. Clinical and pathological data from prior surveillance biopsies was used from both these groups. The clinical and pathological variables used to build the nomogram are shown in this slide. We performed univariable analysis to identify significant clinical and pathological variables associated with grade reclassification. Upon checking for collinearity, significant variables were then fed in a multivariable logistic regression model. Internal validation was performed using bootstrap-corrected AUCs, that is, the area under the curve, and also generating calibration curves. That yielded our final nomogram using the variables of age, PSA density, the period of diagnosis, cancer laterality, risk status, that is, whether the patients were very low risk or low risk, and also the total number of biopsies that the patient had while in surveillance. Our model yielded a bootstrap-corrected AUC of 0.76, as well as the model calibrated well with a slope of 0.86. I would like to note that we use this risk prediction tool currently in our clinic to help inform shared decisions about future monitoring. As we can see in this slide, we have a screenshot of our risk prediction tool that the urologist would see in the clinic. This patient at the age of 70 has a predicted risk of 12% of upgrading on his next biopsy. This estimate would then be very helpful for the patient and clinician to make decisions about how often should future biopsies need to be done. We would like to update our risk prediction tool by adding novel measures of multiparametric MRI, germline DNA, tumor gene expression assays, and results from newer serum and urinary biomarkers. Lastly, I would like to thank our multidisciplinary active surveillance team, without which this study wouldn't have been possible. I would also like to thank British Journal of Urology International for the opportunity. Thank you.